Hi everyone, my name is Megan Tarvis and my presentation is on sickle cell anemia. We'll start with talking about sickle cell disease. We know it's an inherited genetic disorder that involves red blood cells. We know the role of the normal hemoglobin is to transfer oxygen within the blood to various parts of the bodies and organs, the capillaries and arteries. Sickle cell disease is when that hemoglobin is considered abnormal because of the shape. The lifespan of the red blood cell in sickle cell disease is much shorter because that hemoglobin often dies quickly. Blood flow becomes decreased from the red blood cells becoming stuck in the smaller blood vessels. This can cause a vaso-occlusive event or other serious complications. Sickle cell trait is present, we know, in African Americans, about 8%, the trait. And then there's various forms of sickle cell. The hemoglobin SS indicates the individual has sickle cell anemia. They inherit that S shape from both parents' genes. It's the most severe form. They're going to have symptoms. The hemoglobin SC is a milder form of sickle cell disease. And the hemoglobin AS indicates the individual has the trait and could potentially pass the gene to their future children through genetics. They do not have any symptoms with the trait, but they do have symptoms with the disease. That's something you have to educate patients on, because if they have the trait doesn't mean they have the disease, they won't get the symptoms. Other examples of abnormal hemoglobins are listed below. Risk factors we have to be aware of for both mom and baby. So when mom gets pregnant, vaso-occlusive episodes are more painful and they increase during pregnancy, especially in the third trimester and up to 1 week postpartum. There are increased risks for thromboembolism, both venous and arterial. So there are risks for DVTs, blood clots. Individuals with sickle cells are at risk for infections such as pneumonia, bacteriuria, UTIs, or even sepsis. Acute chest syndrome, stroke, spleen complications, organ failure are also risk factors, and as well as psychosocial health decline. These patients are dealing with a painful disease that isn't always controlled well, so their mental health is often declined. Studies also find that patients are more at risk for preeclampsia and eclampsia. That's something we have to be aware of during pregnancy if we have to induce early or use medications to prevent eclampsia. Maternal mortality, obviously the diseases, the complications I listed above can result in mortality if not treated accurately. And as well as neonatal consequences, the risk of miscarriages, fetal growth restriction, they're not getting adequate oxygen through the placenta, so they're not growing. They won't be at accurate weight through gestation wise. Preterm labor, neonatal, they're also born at low birth weight, as well as at risk for mortality. So subjective and objective data. So patients usually don't have symptoms unless they have like a vaso-occlusive event or infection. So, but some of the subjective symptoms we can see is patients will have pain, they'll feel malaise, fatigue, chest pain, shortness of breath, they'll feel very dehydrated. So an example, like I mentioned, of subjective data based on a complication would be like acute chest syndrome. So they're going to have fever, cough, hypoxia, chest pain, joint pain. Objective data stuff is data we can observe. So jaundice, yellowing in the eyes, dark color urine output, swelling in the hands and feet, fevers, hypoxia, poor growth, and abnormal labs. Differential diagnosis. These are things that patients are presented with symptoms that can indicate like a differential diagnosis. So sometimes providers will think of another diagnosis besides sickle cell when they first presented because similar symptoms. such as sepsis, vascular heart disease, upper respiratory infections. So patients coming in with acute chest syndrome from sickle cell, provider might think it's an upper respiratory infection if they don't know their history. Diagnostic tests. The first test is during pregnancy to detect if there's sickle cell disease within the fetus. When there's a concern, when parents are considered carriers, so if mom or dad are the carrier or they even have the disease, they're going to want to get this diagnostic testing so they can be referred to genetic counseling. So they can test for the following sickle cell disease. Their invasive testing, as we talked about weeks ago, an amniocentesis, which is done 15 to 16 weeks, chorionic villi sampling done 10 to 14 weeks, and also non-invasive maternal blood tests. Any positive for the mutations that have the hemoglobin S or any other abnormal hemoglobin can indicate they have the disease. And then the second diagnostic test is for all newborns screening after birth. So you want to assess for early diagnosis because newborns don't show symptoms at birth. So that's through the blood cord electrophoresis to accurately diagnose the following sickle cell diseases listed there. Positive result can indicate they have the disease or the trait, depending what it shows. All newborns should be tested, like I said, after they were born. So pharmacological and non-pharmacological, there's not a lot of medication you give during pregnancy. Hydroxyurea is a medication to prevent vaso-occlusive episodes and other complications of disease. However, it's not recommended during pregnancy. They increase the risk of congenital abnormalities in the fetus. So it's recommended to discontinue actually 3 months prior to conception. You want to make sure patients are taking their prenatals as well as their folic acid. You want to give a pain control to prevent that vaso-occlusive event from getting severe. Just recommend not to take NSAIDs. You want to consider baby aspirin to prevent the incidence of preeclampsia. You want to also think about heparin for patients that are high risk for thromboembolism, or give it prophylactic non-pharmacological treatment. We usually can give oxygen in the hospital to prevent red blood cells from sickling at the capillaries. Blood cell transfusions are recommended when they have a low count of hemoglobin because the hemoglobin's dying quickly. Increase hydration. So we're giving IV fluids in the hospital, or we're encouraged PO intake. Want to make sure they're well hydrated. And we want to advise for avoid extreme temperatures, high altitude, anything with low oxygen exposures. We don't want to encourage patients to go hiking at high altitudes in the mountains. We want to make sure they're washing their hands and they're washing their fruits and vegetables safely, and staying up to date with vaccines that they can receive during pregnancy besides live vaccines. And they want to mention to seek care if they're experiencing a sickle cell crisis, fever, chest pain, shortness of breath, anything that they're feeling off, they should call their provider or seek care. So other education we can provide is that pre-counseling the risks of OB and fetal complications with sickle cell. If a patient has a history of sickle cell disease and they're trying to get pregnant, you want to make them aware of the complications prior to pregnancy. And you want to advise patients to attend all their routine prenatal visits, as it's very important, and they have more monitoring versus a healthy individual pregnant patient. You want to discuss a pain plan with a patient. Narcotic use they can have, but you want to educate to be aware of neonatal abstinence syndrome after delivery for the fetus. And again, encourage hydration. They should be drinking 2.3 liters a day. That's like 10 cups. And making sure they're aware that they don't have to have a C-section because they have sickle cell disease. So there's no contraindications of C-section versus vaginal. They can have a healthy vaginal delivery if there's no other contraindications. Cord blood, remind them that it can be collected after birth. You want to make sure that education's there, because they want to test the newborn to see if they have the trait disease. You want to monitor the hemoglobin monthly and educate that iron and red blood cell transfusions may be needed during pregnancy. And making sure they're aware that they're at risk for placenta ischemia during the third trimester, especially. So fetal monitoring will be given. So the fetus at risk for fetal growth restriction. So we're making sure we're doing that with the second and third trimester with the ultrasound, ensuring the fetal well-being with NSTs and a biophysical profile 32 to 34 weeks and even after. They're referred to maternal fetal medicine, which is considered high risk. The pregnancy is considered high risk, so they would be also consulted on with them, and also make sure genetic counseling referral is there for the patients, and as well as providing emotional support, because sickle cell is a very complicated disease and it's very painful. They're now trying to support their child during pregnancy, so you want to make sure you're there for your patient. And that is my presentation. Thank you, everyone.